Ladies and gentlemen, thank you for your patience in holding. We now have our presenters in conference. Please be aware that each of your lines is in a listen-only mode. You may submit your questions electronically at any time in the chat field located to the right of the presentation. It is now my pleasure to introduce our first presenter, Chris Hund.
Thanks, Chantel. Hi, everybody. This is Chris Hund, Director of the American Hospital Association's Team Training Program. Thanks for joining us for this July monthly webinar. I know it seems from the chat box it's hot and humid most everywhere around the country, so I hope everybody's staying cool and everybody's having a good summer. Today we are going to be joined by a team from Ursuline College in the Cleveland, Ohio area, and we're going to be talking about expanding TeamSTEP's reach in IPE, hospital orientation programs, and long-term care. So really great presentation for you here today. Just some rules of engagement for today. We could listen to the webinar, it's audio in two different ways. You could listen through your phone. If you do that, you're going to want to mute your computer speakers because you'll get some bad feedback, or you could listen through your computer. We're going to do a question and answer session at the end of the presentation. So the best way for you to get questions to the speakers is to type them into the chat box you see on the right-hand side of your screen as you think of them. We'll answer some questions as we go, especially if they're technical, to try to get you connected or if you're having any issues, and we'll answer other questions as we go as well. Then what I'll do is I'll try to compile them all and do a question and answer interview style at the end of the presentation. We've got some upcoming team training events. Our next free webinar is on August 8th at 12 p.m. Central Time, and that is with Dr. Jason Chang, and it's From the Cockpit to Your Operating Room, Strategies to Empower Leaders to Lead. And what's great about this webinar, as well as our August webinar, is that we have speakers from our recent national conference. That's why we didn't have a webinar last month, is that we all got together and gathered in San Diego, California. And so looking forward to sharing some of the great things we've heard from some excellent speakers over the next couple of webinars. We have spots available in our master training courses. So you can see there we have some things happening. One in Seattle in August. The same University of Washington team will be coming out to Colorado to do a master training course in September. And then we have courses with Metro Health in Cleveland and Duke University in Durham. Also, pretty soon, hopefully, we'll be announcing the location of next year's AHA Team Training National Conference. So look forward to that. If you need anything, please make sure to shoot us an email in the future at teamtraining@aha.org or give us a phone call. You could also head over to our website to check out some content and information about any of the courses that we have, any of our previous webinars. We have recordings. So a lot of good stuff there and a lot more stuff to come over on that website as well. So we will keep making announcements and getting new things out as the year goes on. Okay, today's presenters. We have a great group of 3 presenters, all from Ursuline College. We have Laura Goliach, who is an associate professor at the Breen School of Nursing. We have Gina Prosser, and Gina is an assistant professor as well at the School of Nursing, and Pat Sharpnack, who is the dean and the Strawbridge professor at the Breen School of Nursing. So all of these folks are from the team at Ursuline College. They have been doing some incredible work, not only in Ohio, but with teams around the country on interprofessional education around TeamSTEPs. So I think this is going to be a great webinar for you today, and I hope you all enjoy it. So I'm going to toss it over to the team.
Thank you, Chris. Hello, everyone. On behalf of Pat and Gina and myself, it's our pleasure to be presenting this webinar on a beautiful day from Cleveland, Ohio. We wanted to first thank Chris Hund, Jennifer Braun, Abby Avinsky, and Rachel Vandervoort for all the support they have provided along the way in our Team Steps journey. So it's been a few years now, but we greatly appreciate their innovative thinking and team spirit. So always being open to new ideas is really important and very much appreciated. We are on the heels of a very successful and exciting national conference this past June, and are already looking forward to the next year. We hope to meet everyone here and there next year at the national conference. Thank you to all participants on this webinar today and giving of your time. We are truly grateful for and share your passion in exploring and operationalizing new ways to advance Team Steps. So we know what this means for patients and team resiliency. We would also like to say that there are no conflicts of interest in this presentation or have anything to disclose. A little bit about our Team Steps journey here at Ursuline College before we start. Ursuline College is located east of Cleveland. It's a private liberal arts college. It offers undergrad, grad programs, women-focused, highly diverse, with approximately 1,200 students. But the largest program on campus is nursing. We have faculty that thinks in an innovative way and knows the importance of team think and being able to perform effectively in teams. So although we have to reach out regionally for some of our IPE and other experiences, internally we can get things done pretty quickly here, and that has been key in our integration efforts with Team Steps. So we are continually reevaluating Team Steps integration throughout our nursing curriculum, voting, getting things done, voting, getting things done, and we collaborate with our local practice partners regularly on what our students need to be better team players. Faculty is all master team trained, which has been key for us. So it has been a big ongoing journey, but one I know you would all agree is well worth taking. Team think, for the most part, is not innate, it is learned, and when better to learn about teams than early in education. So the learning objectives today are focused on 3 areas of integration. Number 1, summarization of the steps in one model for an IPE experience. Number 2, strategies and long-term care implementation. And number 3, describing how we integrated Team Steps into one of our major local hospitals' orientation programs. We have found that Team Steps is a universal language and builds regional relationships and beyond. So it's a bridging, it's a partnership. So again, we will look at IPE, long-term care, and hospital orientation residency programs. For Integration 1, IPE experience, we'll just look at one model. Here is what we know. When there is effective interdisciplinary collaboration, patients are safer and receive higher quality care. So we must embrace the needs of the system. We must be aware and look at barriers and troubleshoot and promote the interprofessional collaborative competencies. We will discuss a tailored program that we worked jointly and collaboratively to develop, its delivery, and some possible measurements for you. So the needs of the systems and barriers, obviously to err is human. The IOM report is very well documented and widespread. It stunned the nation with the numbers of preventable healthcare errors. Some subsequent reports are showing no huge move of the needle, and in some reports, more errors. So always in those top causes in a root analysis are communication issues, team breakdowns, silos. So whether a standalone health profession program or a large multidisciplined academic medical center, teaching institution, opportunities for IPE, interpersonal education opportunities, can be limited or even non-existent. Time and schedules get in the way. Even with the best intentions, students are at various levels of knowledge and experience in their programs. Resources are limited, manpower, venues, etc. The IPEC competencies, the Interprofessional Education Collaborative, we must be aware of the consortium that was developed that of health profession programs that join together to promote and encourage interprofessional learning. So they recommended the following common core competencies, which I know many of you, if not all, are aware of to guide curricular development. The values and ethics, roles and responsibilities, interprofessional communication, teams and teamwork. So each of these domains can be operationalized very effectively by use of TeamSTEP's tools and strategies and integration of its constructs. TeamSTEPs can be easily crosswalked to all of the domains. Important for students and patients, we know, but also very effective demonstration of the IPEC competencies for your credentialing bodies. So what tailored program model will we discuss today? In this particular model, it started with a simple conversation between nursing, medicine, pharmacy, and allied professions, such as PT, OT, dietary, respiratory therapy, speech therapy, social work, and sometimes even local chaplains. So what were our goals? Well, to provide interdisciplinary experiences for students using the TeamSTEP model that promote critical thinking and collaboration. Scheduling for this particular experience every spring and every fall on Fridays. Case study development. Each discipline had a representative to add their assessment and troubleshooting into the mix to a basic case study. Case studies varied from a homeless Vietnam veteran to a newly diagnosed teenager with multiple sclerosis or another disease. The intervention, we made this experience mandatory and basically conducted class that day at the medical school facility where the IPE experience took place. This correlated well to the senior practicum experience objectives. The course coordinator for the course facilitated this experience as well as other available faculty. Intervention prep work, students were required to complete some preloaded modules based on the TeamSTEPs Fundamentals program ahead of time. And that was key to kind of getting off the ground for the experience. Delivery. The experience was approximately 3.5 hours long and with 2 breaks. Students were placed at tables of 8. All different disciplines were at the table with 1 faculty facilitator at each table. Approximately 100 students per intervention. We began with an icebreaker, as always recommended with TeamSTEPs interventions, and we used the spaghetti and marshmallows for the team building. Table teams then collaborated on a case study and how they approached the plan of care for the patient. Then teams proceeded in groups to posters discussing the TeamSTEPs tools and strategies that might apply to the case study. Teams then convened in interdisciplinary huddles with expert facilitators to discuss their ideas and contributions to a plan of care. Each team then came back to the table and developed 1 plan of care from that table. At that time, a trained, standardized patient joined each table, either representing the patient or a family member, contented or not contented, and they had to address the plan of care with the patient. So debriefs took place at each table, and the patient or family member, as well as the large group, debriefed. Measures. So the team debrief rubrics were provided for each table facilitator. Students were asked to write an online reflection due within 24 hours of the experience. Instrument-wise, we are continually exploring instruments. Always the use of the TTAC, the TeamSTEPs assessment questionnaire, is always a part of the experience because, as we know, attitudes are important determinants of behavior. TeamSTEPs evaluations were given in hard copy immediately after the experience, the reflective assignment, and a 3-month update on the use of TeamSTEPs tools and strategies both personally and professionally. Lessons learned. So prioritize IPEs. Encourage faculty to become master's team trainers for buy-in and investment. Meet with interdisciplinary faculty, and conference calls will do. Brief, huddle, debrief throughout. Provide didactic or online programs to front-load students on team steps. QI, 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 and that's, in part of that whole brief, huddle, debrief process. Provide students and faculty with the dates and times ahead of time. 6 months if possible. Encourage to reach out to retired health professionals, alumni, faculty, staff to help you build this program. And lastly, anything is possible. What is next? Earlier integration is a goal for sure. Is it online learning communities from day one? Believe in the mission, believe in teams, and it is possible.
Well, thank you, Laura. Good afternoon, everyone. In this section, we'll review opportunities and strategies to collaborate with long-term care settings, the barriers to teamwork and increased need for effective teams, team step strategies helpful in long-term care settings, the existing learning environment, and other tools and strategies to engage long-term care leadership in team steps implementation. I'm going to share my recent experience with a privately owned nursing home chain in Huntsburg, Ohio, as well as my experience of over 20 years within the long-term care environment in the role of bedside nurse, nurse management, and administration. Like most healthcare environments, there are certainly specific needs and barriers within the long-term care environment. There are multiple disciplines within long-term care, but the most human resources are found within the nursing department. And within that environment, we find that the number of unlicensed workers is high, the number of LPNs to RN is greater, there are varying levels of training, knowledge, and skill. Clinicians and non-clinicians may be contracted services, especially therapy services, licensed nurses, and unlicensed nursing assistants. Staffing of a long-term care facility is different than acute care settings. It's not unusual for one nurse to be responsible for 20 or even 30 residents, depending on the shift and type of unit. Turnover, especially unlicensed and licensed nursing, is concerning. Resources are not plentiful, especially education dollars, and the resource of a designated staff education member. Staff education responsibilities are often incorporated into an existing full-time role. The physical presence of team members is also challenging. Physician visits are not a daily or even a weekly expectation. The contracted pharmacy and pharmacist is likely off-site. The reporting handoff structure may vary. Inquire within the facility of existing vulnerabilities. Do the shifts overlap to allow for person-to-person handoff? Is there a consistent brief, huddle, and debrief? Are there consistent tools utilized for transitions in care? Communication is a major concern in long-term care, not only between licensed and unlicensed staff, but between administration and staff. The highly regulated and reimbursement-focused environment may impact the perception of the care provider regarding organizational culture and values. Considering these points and many others, we understand there's a great need for collaborative work environments and teamwork in long-term care. The time is now. The most recent State Operations Manual Appendix PP November 2017 revision speaks to specific training requirements. FTAG 940 states, a facility must develop, implement, and maintain an effective training program for all new and existing staff, individuals providing services under contractual arrangement, and volunteers consistent with their expected roles. A facility must determine the amount and types of training necessary based on a facility assessment. And further on, training topics specific, FTAG 941, specifically targets communication. And it reads, a facility must include effective communications as mandatory training for direct care staff. The expected implementation is November 28, 2019. The guidance for the regulation specifically mentions conflict resolution as a key skill. So how do we network and create interest for TeamSTEPS in long-term care environments? Think about the possible connections that already exist or are within reach. Is the nursing home a partner in education? Is it a nursing school clinical site? How about a graduate nursing NP clinical site? Is there a staff development department or staff trainer? I initially met the team at the facility because our School of Nursing was looking for new clinical partners for undergraduate clinical experiences and nurse preceptors for the RN BSN nursing leadership students. This is how our relationship started. What are the past relationships? Is the nursing home a prior workplace? Have you met clinicians or administrators from past education events? Did you, a family member or friend, have an experience in the facility? Do you have a board member contact or do you sit on a board? Seek out professional organizations within long-term care, within the state and nationally. For instance, there's Leading Age. In Ohio, we have the Ohio Healthcare Association, the National Association of Directors of Nursing Administration and Long-Term Care, or Nurses Improving Care for Health System Elders. Consider initial TeamSTEPS education in a seminar presentation format or even webinar format. This will get the interest piqued and the conversation started. Is there potential for participation in quality improvement projects? What are the clinical initiatives of the long-term care facility? How can TeamSTEPS intervention add to the action steps of the project? Team structure and roles may overlap or become fragmented in long-term care. For instance, the charge nurse role and position duties of the LPN and RN are very similar, but this may cause discord between the licensed nursing team. Licensed nurses may lack leadership training. The oversight and supervision of unlicensed care providers challenges the skill of the licensed nurse in areas of delegation and feedback. Communication between the disciplines is critical. Nurse, therapy, social work, dietitian, and physician communication is critical to the overall care of the resident. However, if the role, skill set, and access are not communicated and understood, fragmentation of care results. So it's not surprising that during the training at the long-term care facility, the most valuable TeamSTEPS strategies were the team structure and team building exercises, CUS, 2Challenge, and SBAR. The most effective delivery method was the use of case scenarios specific to the long-term care environment and situations common to the facility. So before introducing TeamSTEPS to a long-term care facility, have the conversation with administration, management, and unit staff before the training begins. Ask these questions. What are the vulnerabilities of the facility? Falls, emergency room visits and rehospitalization, communication between team members, lack of teamwork, delegation, feedback, or follow-up? Here are a few exercises used to facilitate the constructs of TeamSTEPS. In training the nursing home staff, an exercise in team member roles help the staff appreciate the value of other team members in overall operations and clinical care. We used a scenario of brief, huddle, and debrief of a resident on new blood pressure medication, experienced dizziness, and difficulty assisting with transfer from bed to chair. This involved the nursing assistant and nurse dynamic. The desk technique was used for a scenario on a skilled nursing unit and a stressful situation that caused unprofessional nurse behavior. CUS scenarios included the nursing assistant leaving the unit without reporting off to the charge nurse, a physician ordering a psychotropic for a confused older adult, and a situation involving an anxious family member interfering with medication management. We also combined the use of CUS and 2Challenge in a scenario of a patient fall with pain and the indifference from the physician office nurse taking the call. So these learning exercises were relevant to the facility. Also mix up the disciplines for group activity. I recall a dietary aide that was very quiet at the beginning and then became so engaged with other team members that by the end of the session she was offering feedback to the director of nursing on how to improve a unit process. The location of training and room size will direct your training capacity. For this facility, the room size ranged from the basement employee lounge to the common room. Don't overcrowd the location and work with what's available. Know this before, so planning and scheduling is organized. And of course, administrative support is essential for culture change. This means training of all personnel, adequate coverage for training time, and available resources of TeamSTEPS materials. Engagement of the entire team is a long process and one that requires a sustainability plan and facility champions. This requires a higher level conversation. I urge you to have the conversation with the owners, CEO, Director of Nursing, Administrator, or Board member of a long-term care organization. This is a conversation that I had with the nursing facility to plan a sustainable training, implementation, and measurement of outcomes. What is the mission and vision of the organization? What are the strategic initiatives in place? What is the return on investment of TeamSTEPS training and culture? Why is it important to communicate this to practice partners and the consumer? How can the effectiveness of TeamSTEPS be measured? Is it through satisfaction surveys of staff, the resident, and the family? Is it through the quality measures that nursing homes are required to report? Is it through rehiring and retention rates? Is quality and safety a priority of action rather than a plan or policy on paper? Improvement in the regulatory process and expectation of long-term healthcare environments is now one of action. Here are some lessons learned of this experience and future considerations. Talk about resources. It costs money to pull staff off the unit for training. It costs money for activity supplies and trainers. And you also want to consider the location of the training and technology needs. Time management. You may want to consider training in smaller doses when you're in a long-term care facility. Full-day training is difficult in this type of environment. Sustainability. Work with the facility to develop a short-term and long-term plan for training and sustainability. Create champions at the facility level because TeamSTEPS is not a Band-Aid. It's an essential element of culture change. And then, of course, have that pre-training discussion and needs assessment. Thank you, Gina. Good afternoon. It's wonderful to have the opportunity to speak with all of you today about an academic partnership that involved the integration of TeamSTEPS into a nurse residency program at a major healthcare system in Cleveland, Ohio. As the previous speakers indicated, we know that integration of TeamSTEPS assists in building competencies that can improve patient outcomes. While many of our partners in acute care are familiar with some of the tools of TeamSTEPS, they are not necessarily familiar with the program's history, construct, premises, and the scaffolding of the program. So our goal for the partnership and the intervention was to familiarize the system with TeamSTEPS and to improve teamwork and collaboration competencies and strengthen communication skills in newly licensed registered nurses through the use of TeamSTEPS training through an onboarding process and a residency program. So as you can imagine, the needs of a large multi-site yet centralized onboarding system that onboards more than 400 to 600 new nurses in a short time frame is daunting, and it requires significant planning. So what I'll be going through is talking about our collaborative meetings, the needs of the systems and the barriers that we might deal with, the program that we developed and how we delivered it, and the measures that we took to assess our outcomes. Fortunately, we already had a strong history of partnering with the healthcare system through a grant initiative with the Northeast Ohio Action Coalition that gathered both academic and clinical leaders to evaluate nursing program competencies and compare them with a newly designed Ohio Nurse Competency Model. Our attempts were there to close the practice academic gap. We conducted a gap analysis, and through this gap analysis, we identified several areas in need of improvement, particularly in the areas of communication and teamwork skills. Unfortunately, what we found was that most newly licensed registered nurses aren't effectively prepared to communicate with the interprofessional team. In fact, research completed by Lancaster and our colleagues in 2015 found that SBAR provided opportunity for students to demonstrate clinical judgment. However, her findings found out that they could not demonstrate mastery. And Keston in 2011 found that unless there was consistent and repeated practice and critique of SBAR, students were unable to communicate effectively. So the needs identified by the healthcare system included ways to improve critical thinking and clinical judgment skills, enhance communication skills that focused on clear, concise, and targeted communication through the use of the iSBAR tool, and better quality team building strategies to improve retention of new hires. One final goal was to heighten awareness of patient and family advocacy. Our clinical partner and the team at Ursuline College collaborated on the development of a research proposal to study the outcomes of team training, specifically effective use of the iSBAR tool. IRB approval was obtained, and the team worked together to ensure a consistent delivery system, identify suitable faculty trainers, design a workable schedule in a shortened time frame, as we only had about 3.5 hours, in order to adequately dose the learners, and develop materials for distribution that would assist in future reference. We did this over several planning sessions. Once the core team designed the format to achieve the overall desired outcomes and the process by which the program could be delivered, we met with potential master team trainers from the faculty at Ursuline to determine a delivery process that would ensure consistency in content delivery. Standardized and prescriptive teaching methods with taped video scenarios and role play were developed so that all trainers would be presenting the content in a uniform manner. Other matters, such as securing space large enough for roundtables, IT support, and opportunities to use appropriate resources, were managed by the healthcare system. So while the program aims were specifically tailored to address this organization's healthcare needs, they could be easily transferable to any other acute care system. The emphasis was on three key areas. First, ensuring that the attendees understood and could articulate the importance of teams and team training. A second focus was to make certain that the learners were made aware of the TeamSTEPPS constructs and why they were the linchpins to effective team functioning. And finally, we wanted the attendees to gain knowledge of the TeamSTEPPS SBAR tool with a focus on iSBAR, and to develop effective iSBAR responses to videotaped clinical scenarios. As you can see on that slide, it gives you an idea of our delivery system. The instructional team was composed of 6 TeamSTEPPS master-trained nurse educators who were experienced both with TeamSTEPPS delivery and curricular integration, and were extensively prepared in TeamSTEPPS training. The faculty delivered 7 interactive trainings during separate orientations over the course of a 4-month time frame. No 2 nurse educators worked together more than once, and the trainers delivered the identical content contained in a binder. As you can see in the agenda, it has instructor 1 and instructor 2. For example, I was instructor 1 throughout the entire training session. The sessions were designed to be delivered in a consistent manner so that we had study fidelity and that our outcomes could be confidently measured. The training consisted of 6 modules based on the training objectives and constructs defined in the TeamSTEPPS Fundamentals program, with an emphasis on the theory and the correct use of iSBAR communication techniques. Attendees were provided with information about the constructs. They were given video examples of the associated tool and strategies. We had guided group discussions, games. We were able to role play applying the tools in healthcare-based scenarios. We also embedded video examples of effective versus non-effective iSBAR reports in our instruction. We emphasized developing the newly licensed nurses' skills in communication with iSBAR by providing each team with several non-clinical and clinical scenarios for which they were required to communicate iSBAR examples, followed by the trainers discussing the strengths and opportunities for improvement of those reports. Most importantly, we focused on fully understanding the iSBAR tool and developing effective iSBAR communication skills
through repeated opportunities to practice and receive feedback. We also discussed and applied each of the main constructs of team structure, leadership, communication, mutual support, and situation monitoring. During these 7 sessions, nearly 400 new hires were oriented to team steps. For the research, we collected specific data at several points in time. First, we collected pre-intervention data, which was a written ISBAR based on a video scenario simulation. We had the program evaluated by the attendees. We had a post-intervention evaluation 2 weeks later where an ISBAR was done, then again at 3 and 6 months, and finally a post-intervention will occur at 7 months. We are collating the data for consideration, but preliminary outcomes have proven to be both interesting and positive. While we're still in the process of analyzing the income, the use of team steps appears to be an effective strategy for developing communication competencies, and we are looking at the impact it will have on nursing education. Some lessons learned. There are a lot of lessons gleaned from this partnership that involves several layers of management, a research institute, several faculty members, as all of the faculty at Ursuline are master trainers. Some specific takeaways for those contemplating this type of partnership include, first, to realize that the ultimate goal is to get the Team Steps message out there. Integration, both in our program and the Northeast Ohio healthcare community, has been our ultimate goal. So we had to remember to check our egos at the door. Oftentimes when working with larger systems, the need to follow specific processes, negotiate research access and rights, and work with several departments and different cultures can seem to dampen the message. My message to you is to stay focused and keep patient safety at the forefront, because that's what this is about. From the logistical perspective, a number of times the technology did not work. Laptops crashed. Microphones didn't work. Lack of resources happened. Stuff happens. So have a plan B. Bring extra resources because the organization's equipment might be lacking. Be flexible. Negotiating integration can interfere with the format and the delivery of the program. But ultimately, the message will reach the newly oriented nurses. Finally, it was inconceivable to realize that ISBAR was as difficult a skill as it was to develop. What we found that it took repetition, practice, and consistent feedback to get the results we wanted. We realized that sometimes we needed to release our presupposition on what skills healthcare professionals are coming to the table with, and to become more basic in what we initially believe that we have, what we believe our newly licensed nurses need to be. In the end, we did it. Not only did we deliver the Team Step program to over 400 new hires, we strengthened the healthcare system's belief that Team Steps was an effective program to integrate into their orientation process. Feedback from the participants and the practice partners was very positive. So in the end, the goal was and is to improve patient outcomes. The importance of safety cannot be underestimated. And the fundamental approach that we used was using Team Steps. We as a team are looking for where the research of the future will drive us. I would like to quote Don Berwick, who stated, "The concept of safety as a box-checking enterprise where we start and finish is lethal to the patients of the future." We started this process not as a way to check things off a list or to get things done, but rather to change a culture, both in academia and practice, using Team Steps. And we believe that we are well on the way to making a difference in our region using Team Steps as its foundation. Thank you.
Thank you, everybody. Thank you for the great presentation. Really appreciate it. We have some questions that you guys have been answering in the chat as we go, but I think we might want to kind of come back around and hit some of those. I think the one that just came up is about time frame, and I think that's probably a good place to start, is how long are we talking for some of these? For example, some of the stuff you were just talking about here at the end, Pat. What's the time frame on these?
The time frame for the residency program actually took a little over 6 months to prepare. Just planting the seed with the healthcare system. If I have to go all the way back, it almost was a full year when we began to plant the seed with how do we develop this partnership, how do we get TeamSteps into your system. And then over a 6-month time frame, we really worked on an intensive basis, probably meeting at least once every few weeks for a while in order to make sure that we were meeting the needs of both the system and that we as an academic institution could provide them with the resources that they needed in order to make this happen. None of their team was Master TeamSteps trained. They had a limited knowledge. They had read the articles. They knew what Metro was doing, but they were not necessarily aware of all of the issues that, or all of the resources that were available through TeamSteps. So I say plan for a period of time and continually plant the seeds. I think that's key to success with this program, is that we developed the partnership long term, and we also kept planting the seeds of TeamSteps is a great program.
On the residency portion of this presentation, too, we had a question about if there was any evaluation tools that you used or that you knew were available for what you're doing with the residency orientation.
We just used our developed program evaluation. So we used just a program evaluations to make sure that we were adhering to fidelity, that everything was being consistent, and we wanted to hear feedback on the presentation. The other issues, or the other items that we used, were we were trying to get away from attitudes because we felt strongly that everyone feels better after they've learned about teams, and so you do see that increase or improved perspective of attitude about team structure. But we wanted to see what they were doing in terms of ISBAR, and we knew that the team training was the foundation. So we measured actual video scenarios. The first video scenario that they had was a video scenario developed by the healthcare system. They had each of their orientees evaluate or write an SBAR based on that scenario. And they continued to use that as the measure to see whether or not they were capable of having all the components of ISBAR in there. Now, long term, we're looking at the impact of where these newly licensed nurses were at in terms of their residency program. In terms of success, the system uses a program that helps evaluate where the newly licensed nurse is at in terms of practice capacity, whether they have greater or lesser critical thinking skills. So we are also looking at seeing where are they at with what schools they came from, where they were at in terms of knowledge base, whether they were from associate degree program, baccalaureate program. So we're looking at those. But right now, we didn't use any specific tools except for an evaluation tool of the program.
Yeah, I like what you said there about, the attitudes. There's that ARC attitudes questionnaire, but, people often are going to feel great about teamwork. We probably don't want anybody involved in healthcare that says teams are bad.
Correct. So we were trying to move away from this assessment to have something a little more objective.
For sure. There's and I like that you were doing that, especially looking at their skills around things. We all have a question here as well that says, what data and metrics did you use for administration buy-in? Did you have anything along those lines?
We actually use the data that's out there right now with the number of errors, and the system was very interested in improving quality. They're very focused on quality, so there wasn't an issue of buy-in. The issue really had to do with taking pieces away from their current residency program and using TeamSteps instead sort of like an and/or. And
Yeah.
that was part of the buy-in, is to really get the orientation team to see that this was valuable. And I think part of it had to do with the reputation of Ursuline in the community. We had a number of, we had worked for a long time with the system. They knew that we are very focused on quality and safety. We were the team leaders of that Northeast Ohio Action Coalition, as well as the grant associated with that. So they knew of our efforts. So I think some of it has to do with credibility, but I think the other point has to do with making certain that we were providing the resources to them without an expectation of something back. Our focus was truly on, we want to see our newly licensed nurses be prepared appropriately. And since all of our students have the fundamentals program before they leave our program, the question was also, do we see a difference in our Ursuline graduates? And Ursuline graduates have a good reputation in the area for their capacity to really be team members and leaders in the healthcare system. So we really didn't have to sell it. It was really figuring out the logistics of how would we fit this into the orientation process. And they also asked about several research articles, and I will definitely have those available to you.
Sounds great. Thanks.
And Pat, I would add the critical access hospitals. There's a lot of literature out there, reports of very significant changes as a result of Team Steps. So to Pat's point, we do bring those articles and reports forward, which are very powerful for students. We've also had students come back on their willingly. We're not even looking at longitudinal data, though that's in the future, about Team Steps tools and strategies they've used to avert healthcare errors. So that's pretty powerful testimonial.
Yeah.
And so we do have that.
That's a good point, Laura. On the portal, the Team Steps portal, we had a video actually of a new graduate who had used CUS and the outcomes that occurred, and we've had some testimonials from our students which have been very powerful.
When and this is kind of for all of you in thinking about this, Northeast Ohio, there's a lot of institutions that have really run with Team Steps, and your students are going to those institutions already walking into something where they're in an environment that this is going to be used, so they're well prepared. What do you think about how would your students go about dealing with a situation if they went into a system where this really wasn't a part of the culture, or it wasn't really something that people knew about yet? Have you had any instances of that, of students coming back to you and saying, hey, this is a real challenge, no one's using this where I go, or how do I affect change, especially as a new employee and new to the field?
You want me to answer that, Laura?
Sure.
We have had instances of that, and we do have in addition to the Team Steps training, which occurs, throughout, they have Team Steps integrated again throughout the entire curriculum, but they have the foundation course, but we really do stress the change process and how do you establish a culture where Team Steps, you don't have to use the words of Team Steps, but you can use the constructs and begin to develop your team. In fact, we use brief as part of our culture here. Instead of using pre-conference, post-conference, we ask our clinical faculty to use brief, debrief, and do a huddle. And so we educate our students about doing that regardless of what system you work in. You need to use these tools and strategies and use them. It doesn't have to be integrated into your system for you to use the tools. And people will pick up from you. I mean, that's part of being a leader, and that leadership linchpin that holds all of the other constructs together in the Team Steps program.
I love that. Yeah, that is something that I think is really vital, is that with some of these tools, they don't take a lot of training. There are things that you can start using. You can start, you can start checking back with people and doing closed-loop communication without any training of the other person that you're working with. So that's pretty great. This is going to Gina. What do you think the real key is to implementation in a long-term care environment? Are there any case studies that you know of that have already come out? I know from our perspective, there's a version of Team Steps for Long-Term Care that we worked on with AHRQ some time ago, but there haven't been any case studies that came out of that yet. So what do you think those top takeaways are?
Well, I think the key to implementing Team Steps in long-term care, because of the barriers, I think the major barrier is a budgetary barrier. And so it is really the buy-in of the administrators and the CFOs of the organization to put forth the budget in order to have the staff trained. And what's interesting, Chris, is that in the new in the State Operations Manual revision, in FTAG 838, there is a regulation that's called facility assessment. And within that regulation and the guidance for that regulation, it now uses the specific language that how is the organization going to provide resources, meaning money, to educate their staff in areas to improve patient care. And I think part of that really needs to be that training on how to have build up your teams, improve collaboration between the disciplines, Team Steps training, communication. So I'm really happy to see that within the regulations. So long-term care organizations are now becoming more accountable because it's part of the regulation. We know that there's good long-term care environments out there, but this will help the good long-term care environments become great ones. But I think the key to implementation and really capturing the attention of the staff and administration is to use scenarios that are relatable to that specific organization, because for those of us who have been in long-term care over the years, our buildings are unique, yet we also share common situations that happen. And I think those are the scenarios that work well, that you can relate to long-term care because we're a culture of our own, and that we are relatable to that specific area, size of the building, the type of staffing. That's why those pre-training conversations with key members is so important, because you want to create the interest. You just don't want to be there teaching and the audience is not listening. You want to capture their attention because what you're saying is relatable to their everyday lived experience.
Thank you. I think the last thing, and we got about 5 minutes left, and so I know that a number of you and your fellow faculty are master trainers at Ursuline. So have you utilized the tools for your own work as academics, and working together, communicating better as a team? Because I often feel that people ask us these questions of, I understand how I teach this to my students, but I don't know how I'm going to use it myself in the academic setting. So I was curious if you've done some thinking around that or anything.
Yes. Absolutely. I'm laughing because my perspective is the culture has to exist in the faculty. You have to walk the walk and talk the talk, and for us, it is always a struggle. I mean, we call our meetings, let's debrief. We use the language very well. I would say we're dealing with academicians, so sometimes doing an SBAR format is virtually impossible. But we really encourage people to use, we try to think outside the box, and that's what we were doing in the residency program, is getting them to think from the perspective of, you just don't use this in your work life. If you begin to train yourself to use it in all aspects, then you become more efficient because you're thinking in a different mode. And when I was talking about the research, that was part of the issue, is that if you can get yourself in the, well, what they found is that students couldn't get themselves to think in a logical, critical thinking format, and that's the same thing whether you're dealing with faculty or students. It's how do you think in a logical format that allows you to come up with solutions, not just think of the problems. So we attempt to do that here at Ursuline. I don't know if Gina and Laura, if you have anything to add to that.
No, I agree with what you're saying, Pat, absolutely.
Me too as well, Pat. And it's almost like in a flight that you take. The steward or stewardess, describes the oxygen mask for you first. And so I think you really have to look at the team and resiliency within the team. And I know many of the tools and strategies, mutual support, et cetera, we integrate into team and a wellness initiative. So, it is absolutely correct, Chris. I mean, we've got to own that first. And I can tell you on some, as we travel the country, that can be a need in faculty teams. So very important to have buy-in, embrace the constructs, and use the constructs within the team first before you can really, truly integrate it elsewhere.
Agree.
Thank you. And yeah, we've definitely seen some people agreeing with you in the chat box along these lines too. So that's pretty great. Well, we are at the top of the hour almost, so I want to take our last minute to thank all three of you for taking the time today to do this. I really appreciate having you on and for giving such a great presentation. I think we had some good discussion too, a lot of interested people in the chat boxes, so thank you very much.
Thank you.
Thank
Chris.
you.
Well, thank you.
And for everybody that attended, thanks for attending today. We appreciate your continued interest in this and in building this community and really keeping this movement going. That's the way we like to think about this, is that this is a movement that's really going to change healthcare around the world. So thank you all for attending today, and we look forward to hearing from you and also seeing you at the next webinar, which is in August. So thank you, everybody.
Thank you very much. Ladies and gentlemen, at this time, this concludes today's presentation. You may disconnect your phone lines and have a great rest of the week. Thank you.